Thank you everyone for joining us today. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. And today we're going to be talking specifically about policy and reimbursement. The last 18 months has heralded a tsunami of interest in telehealth and in all things related to virtual care. And there's been many waivers throughout the COVID pandemic that have made it easier to use virtual or video conferencing platforms to deliver care to individuals. So we're going to go ahead, I'm going to share my screen and we're going to go ahead and go through this presentation. I do encourage you to either use the chat box, the chat box to ask questions, or you can unmute yourself during the presentation so that we can keep it as interactive as possible. I have to click the right button. Here we go. All right. Trying to change my view here. It's not playing nice on me. All right. Well, let's see if I can do that. Okay. That's what I wanted to do. Okay, so today's virtual hours, as I said, are all about telehealth policy and reimbursement in the UMTRC region and where we stand right now with policy and reimbursement for our 4 states, Illinois, Indiana, Michigan, and Ohio. This week, hopefully you're all aware that this is a Telehealth Awareness Week. This is the first time that the ATA, or the American Telemedicine Association, has done this, and there's been tons of events going on all week celebrating the things that are going on in the telehealth field. I never start a presentation without mentioning my sister telehealth resource centers. So there are 14 telehealth resource centers around the United States. We represent the LILAC states, Illinois, Indiana, Michigan, and Ohio. But you also see states in other colors as well. And then we also have the 2 national centers, one for telehealth technology and the other for telehealth policy. And I'll be mentioning the policy center later on today. So the National Consortium of Telehealth Resource Centers is a group of the 14 telehealth resource centers. We're all federally funded through HRSA and the Office for Advancement of Telehealth. And we do have a main website. You can go there, and there's a national telehealth webinar series once a month, usually on the 3rd or the 4th Thursdays of each month at 2 p.m. Eastern. And there are tons of resources highlighting the many resources from the 14 different telehealth resource centers. Here at the Upper Midwest Telehealth Resource Center, I consider us virtual librarians, especially during the pandemic. The vast majority of the work that we've done has been virtual. So we do a lot of individual consultations for technical assistance. Those might come into us through our website or via email or phone call on our 800 number. We also help organizations doing project assessments and then give updates on policy like what we're doing today. We do our own webinar series. We started a podcast series called A Virtual View. We also have virtual office hours, and we've done telehealth workshops, and we'll be bringing those back soon. We did those in the spring of last year, and we're putting the final touches on our demo center. So here in our Indianapolis office where I'm at today, we've amalgamated some demo equipment from a variety of different telehealth technical vendors and platform vendors so that individuals can make an appointment and come in and see that technology in face-to-face and actually get to play with it a little bit. So let's roll the calendar back about 18 months. In March and April of 2020, when the pandemic truly hit the United States, and many states were shutting down essential traffic and essential workers only. In the field of healthcare and reimbursement, CMS over the month of March made enormous changes in the way reimbursement was going to happen via telehealth. And those waivers for the Medicare patients or Medicare beneficiaries are still in place today. So CMS added about 80 new CPT codes, and there were many questions around audio-only codes. What if you were trying to provide patient services only using the telephone? And the codes 99441 through 99443 were added for audio-only services via telehealth. There were huge changes in geographic barriers. Medicare, traditionally, the patient had to be at a healthcare site, at an originating site, and they had to be in a rural area. With these waivers that came out of the COVID-19 pandemic, now rurality doesn't matter. So even urban beneficiaries can receive telehealth services at their home. One of the bigger things that we saw were expanded roles for certain specialties that had never been able to practice telehealth before. So we still have, for Medicare beneficiaries, expanded roles for occupational therapy, physical therapy, and speech language pathology. There were additional waivers around how often a patient could be seen at a skilled nursing facility. It's now every 14 days instead of every 30 days. And also for inpatient in a hospital, it's now every 3 days. So these waivers really change the landscape of telehealth. And if you start talking with people that are familiar with telehealth policy and Medicare policy, they might say that we've jumped forward 20 years with the pandemic. So telehealth has kind of been the silver lining in the pandemic. At first, all of the barriers for HIPAA were kind of set aside, and they were not pursuing use of a non-HIPAA compliant video conferencing platform. Today, now that we're 18 months into this, we really recommend that you make sure you're using a HIPAA compliant platform for your telehealth services. So in the beginning, towards the beginning of the pandemic, CCHP put out information on the 2021 physician fee schedule that came kind of right in the middle of the pandemic. And CMS was trying to let everyone know what were all the waivers in place and what could and couldn't be billed via telehealth, and talking about continuing to expand the list of CPT codes and HCPS codes that could be used for telehealth. So there were many things listed in this. This is the link here, and you'll get these slides afterwards to this particular fact sheet. CCHP is the Center for Connected Health Policy. They are our national policy center. They do an awesome job at boiling down the thousands of pages that come out in rules from CMS, HHS, etc., and really drilling down the most salient points that we need to keep in mind. So in December of last year, and historically this is the way it goes, every July CMS releases the proposed physician fee schedule for the following calendar year. And there's a comment period for this year. The comment period ended September 13th, so not too long ago. And then usually in December is when the final physician fee schedule comes out that will come into effect January 1st of the following year. So last year in December of 2020, we got an early holiday present. December 1st of 2020, CMS released the final physician fee schedule for 2021. Typically that gets released at the end of December. So we had some additional time to review that before those codes took effect. So what CMS said in the 2021 physician fee schedule is that they took about 60 of those 80 new telehealth codes and they put them in what they call the Category 1 telehealth list. So these were codes that were now permanently part of the Medicare eligible codes for telehealth services. Now the others, they put into a category that they're calling Category 3 telehealth codes, that they were going to be available until the end of the year, during which the COVID pandemic or the public health emergency at the federal level lasted. So you see those here. And they are really, if you compare the two lists, they're really just the more time-consuming or detailed codes related similarly to the codes they did add to the list full-time. So again, as I was saying, that those Category 3 codes, CMS said that they wouldn't continue after the end of the public health emergency, but they did add a new HCPS code G2252 for audio-only services. So they were indicating at that time that those 99441 through 99443 would not continue after the public health emergency. And again, those are those audio-only codes. Well, when the 2022 physician fee schedule came out in July of 21, now they're saying that no longer are those Category 3 codes going to be just until the end of the calendar year during which the public or the pandemic lasts. Now they're extending those Category 3 codes until the end of December of 2023. So instead of the end of 2021 or sometime in 22, they're extending them till 2023. So this allows additional time for CMS and their analysts to look at the usage of these temporary codes around telehealth, as far as how much are they being used, how often are they being used, how big of a change do these audio-only codes make in telehealth usage. So this historical process between proposed codes in July and final codes in December, this has been in place since 1992. So this year's proposed codes have really expanded that whole process since they're now considering those temporary codes to remain until December of 2023. And again, I go back to our National Policy Center and some of the fact sheets that they've put out about the 2022 CMS fact sheet. Now, again, these are temporary codes, these are proposed codes and proposed changes. At this point, we won't see the final version of the Medicare codes for telehealth until sometime in December. So here's a table that really helps break down all of the different, or I should say probably the most significant types of things that are in this particular proposed physician fee schedule. Now, we did have the Consolidated Appropriations Act that was passed in December of 2020. And in that act by Congress that was passed and signed into law, it was talking about having in-person visits with a beneficiary, and that they had to have an in-person visit within 6 months of that telehealth visit. So kind of a hybrid schedule. They also said that it had to be an established patient. You couldn't see a new patient for the very first time via telehealth. And they weren't sure if they were going to continue to allow patients to be seen from home like we have under the waivers for the public health emergency. And they were wavering on, what does the provider have to have live video? Does the patient have to have live video, or can it be audio only? And then do you need consent if you do audio only? And so there's many things here, again, looking at it from an audio only perspective and some of the legislation around audio only, what would it entail? And then there's also an FQHC and an RHC audio-only proposal. So what they're trying to do in the 2022 physician fee schedule is do a cross-check of all of these different legislative bills, and some are into law, and how do they really want to stand at the end of the day, looking both at individual and hospitals and rural health clinics and federally qualified health centers. Sometimes we see, well, a lot of times we see a gap of about a year. Maybe the CMS will put out a ruling on that's for hospitals, but it won't cover FQHCs and RHCs, and then that comes out about a year later. And the reason for that is they're different parts of the federal code. So it, unless a bill that gets passed and specifically mentions the part of the federal regulations that covers hospitals and the part that covers FQHCs and RHCs. And again, those are RHCs are rural health clinics, and federally qualified health centers. FQHCs are federally qualified health centers. So they're in just different portions of the federal regulations, and that's why sometimes you see differences in the two. But this year they're really trying to bring all of the regulations to the same point for all entities. All right, so here's another grid that CCHP put together just to look at, again, what different features is CMS looking at as far as what will be allowed for geographic limitations across the different legislative proposals, whether home as an originating site is going to last past the end of the pandemic, what's going to happen for audio only just for mental health services, because some bills and some state Medicaid programs have carved out audio only and allowed that to go forward, but just for audio only services, or I'm sorry, audio only modality just for behavioral health services. And then what's going to happen with in-person visits prior to telehealth services? Are we going to go back to prior to the pandemic where we were, that we had to see the patient in person and have that established provider-patient relationship before we can have a virtual visit? Or can we meet that beneficiary and start that visit and have that relationship created and all of the information for creating a health record on that first virtual visit? All right, so I've been talking a lot about the public health emergency, and I just wanted to kind of remind you of the timeline here. So part of this and some of the legislation taking longer this year, which it happens, but part of the change from the Trump administration to the Biden administration was that they had to get a new cabinet put into place. So that means confirmation hearings, and sometimes Congress differs on a candidate. But for the case of, or in the instance of HHS, Health and Human Services, they chose Xavier Becerra to head up Health and Human Services, and he was confirmed and put into office back in March of 2021. And then in April of 21, he did renew that public health emergency until July. So at the federal level, public health emergencies traditionally do get renewed for 90 days at a time. And then again, towards the end of July, we saw HHS renew again that public health emergency. So now it will not expire until the end of October. It still remains to be seen if it will be extended past October, another 90 days, which would take us into 2022. So then some of the things that CMS had said about codes lasting until the end of the calendar year during which the public health emergency sunset would then automatically go forward to 2022. But even we may see an override of that with the 2022 physician fee schedule from CMS that is now talking about extending some of those temporary codes until the end of 2023. Regardless of when that happens, I think that providers that serve primarily Medicare patients should have some sense of reassurance that these codes are now going to last a lot longer than we thought they initially would, and that providing these services via telehealth is not something we want to pull back from. In fact, if we look across the nation during COVID and the early parts of the pandemic, we saw 4,000% increase in telehealth visits. Now, that could be in the range of 75% to 100% of any individual practitioner. And we're starting to see those numbers come back down, but they're settling in somewhere between 25 and 50% of a specific organization's services that are being delivered virtually via telehealth. Okay, so here is a snapshot of the 2021 physician fee schedule. We didn't see that till June this year, and part of that was because of the transition in the leaders at CMS and HHS with the transition from the Trump to the Biden administration. And this happens every time that there's a change in the White House administration, just to get everyone in place. But this is the official 2021 version of the not the physician fee schedule, the Medicare Learning Network telehealth fact sheet. And this is our gold standard for how telehealth codes for Medicare beneficiaries should be used, and guidance around who can be a practitioner, where can a patient be at the originating site, those types of things. I didn't include all of the information. They've changed it up a bit, so if you're used to going out and looking at that, please take advantage of this hyperlink to go out and print out a copy for yourself. But this year in the 2021 version, they did not do this list of codes actually within the guide. So this is an example of what it used to look like in the 2020 telehealth fact sheet and back historically. This year, what they did is they linked to, they said, here, find this list and a hot link on the PDF and download the codes. So it takes you here to cms.gov where you can download the codes. And this, I really think enables, not only does it shorten almost by half the size of the fact sheet, but it allows CMS to go in and update this more frequently. And so you can see that this was last modified in August of 2021. And if you open it up, here's a screenshot of what it looks like. So you can see your codes, your HCPS and GPT codes, your short description of them, and then the status. So this particular code, 90956, is available up through the year in which the public health emergency ends. And then it'll tell you over here if it meets certain requirements. And then you can see some of these are temporary addition for the pandemic and when they were added. So those were added at the end of March of last year. So hopefully it provides additional information, even though it's another step or two to get to the codes. It's more informative. All right, if you are a prescriber, there are still waivers in place about prescribing via telemedicine, and you can see that information here. The prescription has to be used for a legitimate medical purpose, and it has to be a practitioner that is also a prescriber in the course of their usual professional practice. The telemedicine communication platform, or that video conferencing platform, has to include audio-visual, real-time, two-way interactive communication system, and the practitioner has to be acting in accordance with federal and state laws. But this does say you can see the patient for the first time via telehealth and prescribe that controlled substance to them, as long as all of these conditions are met. All right, so I'm going to stop and see if there's any questions at this time before we jump into a deep dive on each state's Medicaid program. All right. Oh, we get something in the chat. That's a really good question. So the question is, can you define the word home? Does this mean any home? I'm thinking of snowbirds and patients who do televisits from work, library, etc. So that is not an easy yes or no black and white question, and I'm glad you asked it. So let's talk about a patient that wants to do a telehealth visit from home or from work or from the library in the state where they reside, and their practitioner is licensed in the state where they reside. Then home technically could be anywhere in that state. And I hope that makes sense. So I'll make the distinction. When we talk about snowbirds that leave and go to a different state, say there's someone from Michigan and they go and spend the winter in Florida, then we have to look at licensure compacts, and if their provider is licensed in the state of Florida, or does the state of Florida, the medical licensure association, I can't remember the correct term, each state's a little bit different, but the say it's a behavioral health visit. So does the Psychiatry Association in the state of Florida allow those with Michigan licenses to practice in the state of Florida? And that could be a yes or it could be a no. Florida has been a little bit more relaxed in allowing providers licensed in other states to still practice in Florida. And I think that's particularly because of snowbirds that come there. But a provider is restricted by their licensure and is only supposed to provide services to individuals that are physically located during that telehealth visit in states where that provider is licensed. So I know that's a lot of words. I hope that makes sense. I'll give you an example, another example. So what if I am in Indiana and my provider is licensed in Indiana and my provider is licensed in Tennessee? I go down to Tennessee on vacation because my Indiana provider is licensed in both Indiana, and I'm from the state of Indiana, that's my home residence. And I'm in Tennessee and my provider is licensed both in Indiana and in Tennessee. I can continue to see my own provider. So I hope that makes sense. Please let me know if it doesn't. Any other questions before we move on? All right, great question. So again, back
I'm sorry, just to
yes,
reiterate?
Absolutely, yes.
So just knowing we have so many snowbirds up in the Midwest, the patient owns a residence in Indiana and a residence in Florida. It goes by the physical location of the patient, correct?
Correct.
Okay, just making sure. Thank you.
Yep. Mm-hmm. And yeah, I think we'll get lots more questions on that. So going back to the Center for Connected Health Policy, they are a great resource, and we've got resources on our website as well. So you might want to go to our website first, and then if you need to dig deeper, you might go to CCHP's website. But what CCHP does is it used to be, and that's what the screen grab on this slide, every 6 months they would update their semi-annual report. So usually October and April, or maybe March. But they would put together a summary and a comparison of the different Medicaid programs in each state. And they always have an executive summary. So they have updated their website and are not going to do their standard 2-year comparison, because now they're updating their website more frequently because laws are changing more frequently. And you can actually do a comparison between states on their website. And they will still do every 6 months an executive summary of the 50 states. But now you can actually go and find that on their website. Here's a new resource that we created, and it's on our website around some of the billing language, which has changed a lot over the last 18 months in different states. Well, it depends really on the insurance being billed, if you're billing Medicare or Medicaid or private insurance. And this breaks things down by state and by Medicare. So you can see the originating site is defined as where the patient is physically located. So when we talked about home, it's not necessarily their physical residence, but wherever they're at during that visit. And CMS recognizes the place of service, or POS02, which is defined up here, the GT modifier, which is defined here, the GQ modifier, which is defined here, and the G0 modifier, which is for telehealth stroke services. The distance site is the physical location of the practitioner during that telehealth visit. Here are some other modifiers that private payers use, GT and 95. In the state of Illinois and in the state of Michigan, their Medicaid programs want you to use the GT modifier and the place of service 02. Ohio, the state Medicaid program in Ohio, wants you to use the procedure code, which is your normal CPT or HCPS code, plus the GT modifier, and show the patient location. We'll get to Ohio in a minute, and I'll show you that. And the place of service code for the practitioner. Medicare wants you to use 95 and the POS02 if in person. As if in person, sorry. And the state of Indiana Medicaid wants you to use the procedure code plus the POS02 to signify that it's done via telehealth, and the modifier 95. And if you want to, you can still use the GT modifier. So this is it's kind of an alphabet soup for those of you that get into the billing and coding. So we put everything on one page here to try and simplify it as much as possible. I know it's still a very, very busy handout, but feel free to use this URL and go out and print a copy for yourself. All right, so let's look at Illinois. So Illinois had some major legislation pass in May of this year with House Bill 3308. So with this bill, healthcare professionals are no longer required to be into the same room as the originating patient unless it's deemed medically necessary. So prior to this, and especially for behavioral health services, they were requiring some other kind of professional in the room with the patient during the visit, which kind of defeats the purpose of a telehealth visit when you have to have someone sitting in with the patient. The House bill in Illinois for Illinois Medicaid beneficiaries also no longer requires an in-person visit before the provision of telehealth services. It also takes away any geographic or facility restrictions, so they don't have to be at a certain physical site. Excuse me. And they also have taken away the originating site restrictions so that patients don't have to be at a specific clinical site. And the other thing that this bill does is something Illinois has been fighting for a long time, is it establishes payment parity. And parity, we talk about parity, it could be parity in coverage so that the telehealth services are covered in the same way that they're covered in person, or it could be coverage or payment parity so that the services are reimbursed at the same rate. So they already had a partial parity law for coverage, and now they have a payment parity coverage just for mental health services, and they're looking at other services as well. Oh, yes, we will be sharing this presentation. We will get these slides out probably the beginning of next week, but you'll definitely get a copy of the slides. And let's see, I think that's it on Ohio, or Illinois, getting my states mixed up. In Indiana, we did have Senate Bill 3 signed into law in April of 2021. This bill did a lot of cleanup. There was a lot of old language, and some places in Indiana, they use the term telemedicine, and sometimes they use the term telehealth. If you've been paying attention to the terminology over the pandemic, it has really changed. So the older term telemedicine historically meant the billing and reimbursement of services provided via telemedicine, those clinical services. But telehealth is a more encompassing term that also includes education, like nutrition education or diabetes education, those types of things. And then even though most policy is now moving to the term telehealth, a lot of times in commercials and pamphlets and advertisements, you might see the term virtual care or virtual visit or some other type of phrasing, because it's really morphing into a lot of things that can be done virtually. Other things that this particular bill did is it added additional licensed providers and that could do or provide telehealth services. It added athletic trainers, chiropractors, dental hygienists, dentists, diabetes educators, dietitians, genetic counselors. Optometrist was already on the list. I'm skipping to some new things. Physical therapist, physician assistant was new. Podiatrist was new. Respiratory care practitioner and speech language pathology and audiology were new. So it really took into heart many of the waivers from the pandemic and put that language into permanent law. Also, this new law in Indiana for Indiana Medicaid beneficiaries allows that provider that acts as a practitioner that directs an employee to perform healthcare services. Now they're held to the same standards as if the services were furnished in person. There were a lot of rules on the books about supervision and those types of things that have had to be updated considering the amount of services that are now provided virtually. There were changes to Indiana code about medical records and how they had to be created and maintained, and they cleaned up that language to be in compliance with HIPAA law. Waived, this is an interesting one. I've only seen this in Indiana, but now if a patient is not in a private setting and they have other individuals around them that can hear their private conversation with their medical provider, then they waive their right to HIPAA. Or they waive their confidentiality, which is in the same waiving their right to HIPAA. So kind of if someone's using a hotspot and they're going to a restaurant or they're in a park or something like that, or even if they're just in a room, in a conference room at work, and there's a lot of people around or that can come in and hear what they're talking about, then it takes the onus off the practitioner, off the healthcare provider, and places it on the patient, where the patient is responsible for maintaining that confidentiality. It is also in Indiana now, Medicaid cannot restrict the physical location of the patient or of the provider. So in essence, that the patient can be anywhere, the provider can be anywhere, and not at just a specific clinical site. And this particular law also repealed some laws concerning telepsychology that created some barriers for some behavioral health professionals. There's another law in Indiana that really talked about community mental health centers, and they were actually never on the list of eligible providers before. So this particular bill allayed that, and now community mental health centers that are providing telehealth services that does satisfy a face-to-face requirement, so that they can provide services via telehealth. And it adds behavioral analysts to the definition of practitioner. So sometimes there are individuals that practice in the behavioral health setting that aren't licensed the same way as other providers. They have just a certificate or a temporary license, and it tried to put those individuals on the same even keel to be able to provide services via telehealth. All right. Any questions on Illinois or Indiana before I move on to Michigan? Okay. So in Michigan, this is an interesting story if you like policy like I do. Back in 2020, Michigan Medicaid was getting ready to start allowing patients to be seen from home when the pandemic happened. So that kind of went into their Medicaid rules as the same time that they had executive order allowing telehealth for all types of services. So this bill 5416 became effective on June 24th, and it actually amended their Social Welfare Act in the state of Michigan, so that beginning October 1st of this year, or I'm sorry, of 2020, that telemedicine services would be covered under the Medical Assistance Program and their Healthy Michigan program for beneficiaries that were at home or in a school setting. Then earlier this year, they did do another clarification in their Medicaid bulletins. So this was MSA 21-24 for asynchronous telemedicine services. So this is an interesting one to read if you're operating in the state of Michigan. It's a little confusing, but they try to clear up some things about asynchronous services and which are allowed and which are not, specifically around remote patient monitoring services. Any questions on Michigan? Okay, and now we come to the state of Ohio. Yeah, Ohio is also interesting because in July of 2019, they started allowing beneficiaries or patients to be at home prior to the pandemic. And it's also interesting because Ohio Medicaid did not start allowing telehealth services to be reimbursed from Medicaid beneficiaries until 2017. So they went from the last state Medicaid program to embrace telehealth services to the first to open up that home location for their patients. So the Ohio Medicaid program has done an awesome job. And again, you can see where our guidelines are at. They have put together everything in a easy to read graph or table so that we can see, and here's those provider types that we mentioned, and we talk about place of service codes. These are their provider types or their MITS types that they would need to put on their bill. So this is several pages long. I'm not going to go through the whole thing. Again, you'll get these slides. And this information is available to you as well in our state reimbursement guides that are on our website. So if you go to umtrc.org and look under resources and reimbursement, you'll see more in-depth and longer reimbursement information specific to each state. And there's one for like hospitals, which is the general one, and practitioners. And then there's another one for each state for rural health clinics and federally qualified health centers. And I mentioned licensures before when we were talking about the physical location of patients. So this is the physician licensure compact, and you can see that the darker states that in the darker blue are actually participating in processing applications for physicians that want to practice in multiple states. Indiana, this was brought forward in a bill 2 years ago, and it did not pass. So they have not adopted this in the state of Indiana. Ohio, it didn't pass a couple of years ago, but it's in the current legislature, so they're talking about it again. This is one of the most recent new compacts. There are also compacts for psychiatrists, for nurses, for EMTs, and many other professions. I think we'll see this a lot more as telehealth services are used more and more. And sometimes we get asked, if you work in the Veterans Administration, the providers in the Veterans Administration can provide services in any state. It doesn't really matter where they're licensed. And that's kind of because they're in a encapsulated environment, only serving veterans. So, what is the future of telehealth? Well, I think it's very bright. We kind of see the writing on the wall with the 2022 physician fee schedule out of CMS and extending those temporary codes for, from the end of 2021 to the end of 2023. So another 24 months that those codes will be available. I think we're going to see a lot of change in the way healthcare services are provided in the United States. I definitely don't think it's going away. So it looks like we got one more question here. Oh, the telehealth provider certification for Indiana. Yes, that is a tiny, niggly little thing. That is way deep down in the weeds. But if you have additional questions on it, feel free to email me and I'll send you the information. The PLA for the state of Indiana, the Public Licensing Association in the state of Indiana, if you are an out-of-state provider, say you're licensed in Illinois or could be California or Florida, that doesn't really matter. You're licensed outside of the state of Indiana. There is a form that the Professional Licensing Association of Indiana asks that you fill out and complete before you start providing services inside the state of Indiana. This has its roots in some legal proceedings, I don't know, maybe 4 years ago, but they are still requiring that. So thanks for bringing that up, Lauren. Any additional questions? Now is the time. I'm going to go ahead and share my, these are the different ways that you can get in touch with us through our website. Here's our podcast, A Virtual View. We release new podcasts on the first and third Fridays of each month. We are available on any major podcast platform. You can search us and find us. We do have a YouTube page, and that's where we will load the recording from today. And we have a Facebook page, we have a Twitter page, and we have a LinkedIn page. So there's many ways to reach out to us. And there's my email if you want to reach out to me individually.